Next slide, please. So on examination, he was having stable vital sign. His weight was 44 kilograms with a body mass index of 70. And he was having pale conjunctiva and buccal mucosa, but no lymphadenopathy was found. The liver was like 7 centimeters from right costal margin, but the total span was almost normal on the imaging, but he has huge splenomegaly that reached to the umbilicus, and it was like 7 centimeters from the lower costal margin along the line of the growth. No ascites, but he was having stress pedal edema.
Paulos, I'm wondering if we want to stop and just hear what people are thinking even at this point before you show them investigations. What do you think?
Yeah, it would be a good point to discuss upon. Yeah.
So we'll invite comments. You can type them in the chat, or you can unmute and speak your comment. We'll take either one. What are people thinking about this patient with abdominal discomforts, chronic diarrhea, has required blood and blood product transfusions, and on exam he's pale and with a huge spleen?
Otherwise, the abdomen was soft, no tenderness. So what do you consider as a possible differential?
Well, Paulos, I guess in one sense we could say, why is it even a GI case instead of just a splenomegaly case? But he's got this chronic diarrhea, which, you know, is not a usual part of tropical splenomegaly, for instance. Does anyone want to chime in? How are people putting this together?
Hi, Paul here. I'm just, maybe just a bit of clarity. I may have missed it, but I was wondering whether there were any pulmonary or neurologic symptoms as well.
Yeah, nice question. So he was not complaining any cough, no chest pain, other than the headache. He was and he has extreme fatigue. Otherwise, no body weakness, no tingling sensation, or any other cyanocobalamin deficiency symptoms was found. Thank you for the question.
Thank you.
So in the chat, Getachew has put visceral leishmaniasis, and Gashahun has written non-mycobacterial TB, maybe Mycobacterium avium complex. Wow, these are great thoughts. Also, we're seeing tropical splenomegaly syndrome. Maybe it has some diarrheal component that I'm not aware of. That would be interesting to learn. Okay, everyone else is silent, Paulos. We don't have, okay, lymphoma. Thank you, Purnima. And Getachew saying hematologic malignancy. Excellent, excellent. Okay. Visceral leishmaniasis, CMV disease. How interesting. Toomey is suggesting that. Perhaps systemic CMV disease in the setting of HIV, a myelodysplastic syndrome. Okay, the neurons are firing. We're getting a lot of suggestions here. GI adenocarcinoma perhaps with metastases. MAC. Okay, so we've got a lot of possibilities on the table here. Paulos, why don't you continue? Shall I advance the slide?
Thank you very much, Prof. So on next, hematologist try to look for any hematologic causes, and she started working up. So the WBC, as you can see, 6,330, which is within the normal range, with 75% neutrophil and 18.3% of lymphocyte. The hemoglobin was low, like it was 6.7, and then it drops to 5. We transfused him 3 units of blood last time. The MCV, the mean corpuscle volume, is 96.5 centiliter, which is not suggestive of iron deficiency anemia or I mean, it's not also megaloblastic type. The platelet is like 11,700, and it also dropped last time to 8,000 when we last determined it, and then we transfused him with some platelets. So the LDH is not suggestive of hemolysis or hematologic type forms of condition with 195, and the C-reactive protein was elevated, like was 40.6. The folate and vitamin B12 level, the folate was serum folate level was within just normal limit of the laboratory tests. So with this, she proceed, the hematologist proceed to possible peripheral morphology and bone marrow aspiration examination, but it just shows myelopiosis with the lift shift maturation. Otherwise, the blast is only 3%, no suggestive of infiltration, no hematologic malignancy feature since with erythropoiesis seen with the normoblastic maturation and few megacrocytes with normal lobulation seen. After excluding possible hematologic condition, we proceed to the next lab investigation. Can I have the next slide, please, Prof? So the next is to have some lab baseline organ function tests like transaminases are within normal range. The albumin is also, you can see it is 3.7 normal, creatine is normal. The electrolytes, sodium, potassium, and calcium are also within normal range. So after that, she sends the patient for further workup in the hematology side because he was also having a kind of lower abdominal pain and long-standing intermittent kinds of diarrhea. So we proceed with the full microscopy, which doesn't show any ova or parasite. But the fecal occult blood test was positive, and other tests like H. pylori stool antigen was also negative. We also screened serologically for hepatitis B, hepatitis C. We also determined the peak. All are negative, you can see. So because of the huge splenomegaly, we go for leishmaniasis and check also for RBK39, which turned to be negative, and we also try to do the brucella, but they brought data from Eritrea that it was being determined there, and screening for brucella was also negative. So we also go for possible tumor markers, including alpha fetoprotein, PSA, CA, and CA99, all are within the normal range. So because of the fecal occult blood test, we go for colonoscopy. So imaging, we also determine as one suggested for possible screening of tuberculosis. We do chest X-ray, and we also try to see if there is any lymphadenopathies with lymphoma, with amyloidosis and the like. So chest X-ray reading came with normal. Limit also the abdominal ultrasound shows there is huge splenomegaly, which is around 15 centimeter, and it was homogeneous in echo texture. Otherwise, the liver is within the range. Along the mid-clavicle line, no irregularity and smooth contour, no mass, no metastasis, anything that has been found. And the portal system and the lights, everything that has been reported was within normal range. All are normal, no other finding. So the abdominal CT scan shows the splenomegaly. The size was tried to be measured, like it has been around 60 centimeter on the CT scan, and they also see that there is some gastric submucosal mass with fat attenuation, and they consider a possible differential diagnosis of lipoma. Otherwise, the spleen, the pancreas, all the liver, the pancreas, kidneys, every other organ was reported to be normal. The vascular system also found to be normal. No portal vein thrombosis, no portal hypertension signs, and the other findings are all within normal range.
So, Palos, it sounds like you have done all this testing and still have really no explanation for his heme-positive stool and diarrhea. And I guess you've already told us you were thinking of a GI workup at this point.
Yes, Prof. Exactly.
Okay. So shall I advance the slide?
Yeah. So with that finding, we proceed with initially colonoscopy and then also endoscopy because we just want to see if the mass was possibly a kind of other than the lipoma. So these are the findings. You can see there is submucosal types of mass lesion in the proximal parts of the antrum, in the lesser curvature, the side of the lateral side of the gastric wall. So I was trying to see any other findings. So as you can see, there was some erythematous mucosal change, and I just took biopsy to exclude possible lymphoma or a kind of lesion that can explain all the scenario in the patient because he was having decreased appetite, significant weight loss, and as we already said, he has also abdominal discomfort and intermittent diarrhea. So this was the finding, but the biopsy turns out to be a normal gastric mucosa with some chronic inflammation. Otherwise, it was non-revealing for any pathology.
Carlos, was the lesion soft? Did it have a pillow sign that you would expect with a lipoma?
Yeah, it was actually kind of just at the under the lower parts of the mass. There was some erythematous lesion. Otherwise, most parts of the tumor looks a kind of normal mucosa with a kind of pillow sign. Yeah, it was also soft. So this is the colonoscopic findings. So that is in the terminal ileum. The first part shows no any lesion in the terminal ileum, and this also was seen in the second. So there was no erosion, inflammation, ulceration, or nodularity, no gastric, mucosal lesion seen in the colons.
Wow, so this is fascinating. So we'd like to hear from the audience. Other ideas. So now you have your endoscopy and your colonoscopy and a biopsy of a gastric lesion. There was a note here in the chat. People wondered if maybe he had Whipple disease, Paulos. What did the duodenal mucosa actually look like? And did you biopsy it?
Unfortunately, we didn't take the biopsy from the duodenal mucosa, but there is no significant atrophy that we have seen. There is no scalloping, no atrophy of the duodenal mucosa.
And was there any sort of thickening of the mucosa, yellowish discoloration, as is sometimes
No.
seen? There's a heavy infiltration of the mucosa by MAC,
Yeah.
for instance. No, okay.
Mm.
Tinsei asks, do we have EUS of the submucosal gastric mass?
Yeah, we can proceed to the next slide.
Okay.
So I wish if Dr. Abdu was here. I just sent the case for him, and we were hoping because we tried to explain everything in one disease entity. Just we doubt the diagnosis of lipoma and send him for endoscopic ultrasound. And the report was just there was some mucosal mass with a kind of fatty consistency, and he just said it is lipoma, and he deferred the fine needle biopsy.
Okay. So what's next, people? What are you thinking? There's a note here from Hailey saying, do we have a splenic aspirate? Interesting. Well, I guess we're looking, what are we looking for there? I guess we already have a list. Malignancy, leishmaniasis, although a blood test was negative. Brucellosis was a very interesting idea. Did he have fever, Paulos?
No significant fever. No low-grade fever or high-grade fever that he complains. He just have a progressive loss of loss of weight and intermittent types of diarrhea.
There are a couple of remarks about GIST, but I have to say that GIST doesn't usually cause chronic diarrhea and anemia unless it's bleeding into the gut. And the GIST usually has a very different EUS appearance than lipoma. So I'm not sure about that one. Paul has his hand up. Paul, please let us know what you're thinking.
Yeah, thanks a lot. I mean, up to here, I'm quite intrigued by the case. Well, a disclaimer, I'm not a gastroenterologist, so I'll think broadly beyond the GI. I'd also be interested in finding out what the occupation of this patient is, because one of the things I'm thinking about is, and probably you'll let us know whether you probably got a ferritin in this patient, because one of the things I would think about is, though the patient is quite old at 73 years of age, but I'll be thinking about possibility of a hemophagocytic lymphohistiocytosis, HLH, and probably do some staging at that point using the 2004 criteria. Because of that bicytopenia, you've said he doesn't have a fever, so that strikes off one of the 8 criteria of the list. But the bicytopenia, the huge spleen, maybe the other thing I would add on there is a lipid profile to check for the triglyceride levels. So that's one of the things I'm thinking about. The other thing I'm thinking about as well is you said on the abdominal ultrasound, there was like some homogeneous picture. I don't know on the abdominal CT whether that homogeneity was also demonstrated or they were just patchy lesions. Because I'm also thinking about possibility. It's just random. I'm thinking about splenic sarcoidosis. I don't know. So I'm just thinking broadly, really, but just over and above the GI. It would be nice to figure out other thoughts as well.
Yeah,
Thanks.
thank you very much.
Yeah, it's great, Paul. You're thinking systemically. This condition you mentioned, hemophagocytic histiocytosis, I have 2 follow-on questions for you, Paul. Would the bone marrow not be diagnostic? And what diagnostic test would you do to assess for that?
Yeah, no, that's a brilliant question. I know I think I've seen probably maybe two HLHs during COVID, and that time it was mostly the hematologist would read it as some reactive marrow hyperplasia. But really nothing much. So normally what we would do is like just stage using the HLH 2004 criteria, because according to that criteria, most times they don't, you don't even need a marrow actually to make the diagnosis. You'll probably just need your, out of the 8 criteria, you'll need at least 5 of those components to make a diagnosis. So I know, if I can remember well, there was fever, at least a cytopenia at the level of from 2 and above, so a bicytopenia and above. You'd require high triglyceride or high fibrinogen levels. You'd require some of course, the marrow findings were also taken into consideration. I can't remember off the top of my head. And the ferritin level as well. We would also require a ferritin level to fit into that criteria. But one of the caveats was that in addition to all that, a marrow may or may not be required. But I do agree that in most marrow cases where there is HLH, there seems to be some reactive marrow hyperplasia, which is not reflective here. So that's why I'm just, I'm not saying it's that, but just, I don't know, it's a possibility, it may not be.
Well, thank you. That's a great thought. There's a question here, Paulos, maybe you're seeing it. What does the spleen look like on CT scan, and how was the description of the portal vein? Was it patent?
Yes, I already mentioned about the portal venous system. There was no any lesions that have been described on the CT scan on the portal system. But the description of the splenomegaly is a homogeneous type of enlargement with homogeneous ecotexture that both ultrasound and the CT report.
So
No
homogeneous
fatty infiltration.
spleen
Yeah.
and a patent portal venous system. There's a question from, sorry, Paulos.
Proceed, Prof.
There's a question from Benyam. Was there lymphadenopathy on exam or imaging?
Yeah. There is no identified lymphadenopathy on the physical examination, as well as there is no reported lymphadenopathies on both ultrasound and the CT scan. That was what we were for initially.
Did you have a ferritin level available?
Unfortunately, we didn't determine the ferritin level.
That's okay.
Yeah, that will be a very good input. Yeah.
Well,
We'll
I think the main thing I'm seeing here, people are asking about EUS biopsy. So I'll mention, as you did, that EUS showed typical findings of a lipoma and an EUS biopsy was not performed. And I guess there was a comment about sampling the spleen earlier. Otherwise, the group seems to be running out of other diagnostic tests to do. Paulos, do you want to continue?
Sorry, it's just an open case. We are just being challenged. How we are out of diagnosis, and we want to hear from the people. So
okay, that's perfect. So
maybe you can share the next slide, and we do have some question, I think, on the.
Sure.
Yeah, that is what we just have. A huge splenomegaly with hypersplenism, requiring blood transfusion and platelet transfusion recently because of the very low platelet count. Otherwise, he was having also significant weight loss and intermittent diarrhea. We failed to explain, and we failed to tie up the causes together.
Okay,
So we want to hear from the group.
Right. So this is excellent. So we love to see comments. So there's a comment that this is all tropical splenomegaly syndrome. What do you think, Paulos? Should we just send the patient back to the hematologist and say, this is your problem?
That will be found in the next slide. Can you do that, please, Prof? So the hepatosplenomegaly, the hypersplenomegaly is malarial hyperactive splenomegaly syndrome was initially considered, and then we asked them for repeated malarial attack, but the patient was he spent most of the time in Addis, and then he went to Eritrea almost 20 years back, and then he has never been out of Asmara, and he has never history of malarial attack, confirmed or even clinically suspected. So, and the tropical splenomegaly syndrome doesn't explain also the weight loss and the other symptoms that he has, the diarrhea also, and we fail to tie up with the hyperactive splenomegaly syndrome.
Biopsy showed H. pylori.
It was just a chronic non-specific inflammation. Otherwise, no H. pylori was described on the.
And no gastric malt lymphoma was described.
No, he has no dyspeptic symptoms. We just have a lower abdominal discomfort usually.
And the question about the patient's occupation, Paulus.
I'm not quite sure, but he is already retired for the last 20 years, as I already described. Since he moved from Addis, he's not in any form of activity. But I'm not quite aware about the previous jobs that he was doing here in Addis.
So there's a question also about and this is an excellent question about a storage disease, such as Gaucher's disease. I don't know much about that disease. I think I would expect it to present at an earlier age. But it raises for me the question of whether this patient has amyloidosis, because he's got a huge spleen which may be infiltrated. It's possible that some of his gut mucosa is infiltrated somewhere in the gut, and giving him some issues with absorption and even with diarrhea. And he lacks adenopathy or fever. Was there protein in his urine?
I don't think we do have the urinalysis also, but we can also determine the urinalysis to look for that.
Or a serum protein electrophoresis and urine immunoelectrophoresis would be very interesting for me. Here's a great question. Can toxins do this? Maybe lead toxicity. So lead toxicity certainly could cause anemia. I don't know about whether it would cause hemolysis or splenomegaly. But thinking broadly here, this is great about toxins, heavy metals. There's a comment, repeat the bone marrow biopsy in case something like fungal infection or another infiltrative process was missed. And I agree with Benyam that often in amyloidosis, if a bone marrow biopsy was done, they may be able to diagnose it. If it was just an aspirate, they may not see the amyloid. Do you want to comment on those things, Palos?
Yeah, the next slide have few questions, bro. Yeah, that is my questions, So what should we do further? As you already said, shall we send the patient back to the hematologist, or shall we send him for infectious specialist, or still we need to stick with the spleen and investigate further? Who should investigate this patient further? Is my first question. And the other one is to have the possible differential diagnosis, as we do have a lot of differential actually already, and what to do next was the point. So we can also do repeat bone marrow biopsy, serum electrophoresis. We take that into account. So we might update you on the after the investigation, and the urinalysis also for protein. Any other suggestions that you can have? The other thing that we were having in discussion was to do some splenic aspiration, but it is a huge spleen and the platelet count was down to 11,000. Will you dare to do splenic aspiration to look for any causes? That was one of the questions. And
so, and then I think one could ask, are you really, he does have, can you hear me, Palos?
yes, Prof, I'm hearing. So the last question
he does
that
have
we were having,
diarrhea and traces of blood in. Sorry, go ahead.
can we kind of consider surgical management, as he was lastly was requiring a kind of multiple blood transfusion? So that was also another question that we are having. So we are open to learn, to have
Palos,
other opinions.
did he have an HIV test?
Yes, it was negative, Prof.
Okay, I missed that. So also, I guess we could ask if you're really done with the GI workup. His small bowel has not been evaluated, and CT scan wasn't done as an enterography protocol, I guess. So that could be done, CT or MR enterography, to
Yeah.
really evaluate the small bowel for a mass or lesion or carcinoid tumor. And then
Yes.
We have other comments here. Maybe a BAL culture for MAC. Just keep transfusing him with platelet. Oh, no, I'm sorry. Transfuse platelets and then do the splenic aspirate. Is one suggestion. Does anyone here have experience with splenic aspirates or biopsies in people with thrombocytopenia? Paul, is that what you want to comment on?
No, sorry. My hand was up way earlier than that. But just to comment on that,
Okay.
but just to comment on that, I personally we've not had a lot of experience with that because I know even in Kenya we have quite a bit of visceral leishmaniasis. And so I know for most patients, what they normally do is that they just do the RK39, especially if they with thrombocytopenia, the RK39 is more or less sufficient because most people are not comfortable approaching the spleen with such low platelet counts. But the transfusion of platelets and attempting it later could be an idea. I don't know. It's possible. It's possible. But why I raised my hand was I just wanted to comment on this slide, really. Honestly, everyone should be seeing this patient. I think these are patients who require real multidisciplinary effort. Myself, I'm an infectious disease physician. From all the workup I'm seeing, I don't know what additional role I would play here because it seems that most of the work has been done. I know there was a suggestion of a CMV colitis, which is possible, but I would have expected it in a severely immunocompromised patient, which does not seem to be the case here. I don't know what additional role myself would play within the infectious disease realm. But the additional GI workup for sure would be very welcome. I personally would love to have looked at the abdominal CT image a bit more keenly, especially at the spleen, because I would have really wanted to see that homogeneity that was seen in the ultrasound, whether that is the same reflection on the CT or there were multiple lesions as well, because that would be really interesting as well with possible isolated splenic sarcoidosis. If it were possible, I would also do the lipid profile and just assess possibility of hypertriglyceridemia, and also do a ferritin if it is possible to do a ferritin in that setting, just to see whether I can get the workup for possible HLH. In terms of the occupation, I know I asked this question a lot, but why I asked the question for occupation, even if it is previous occupational history, I think for me is that normally sarcoidosis tends to be in people who inhale a lot of spores, like firemen, like people who are firemen previously, people who did a bit of farming previously. Such history is also quite important when you're working up someone for possible sarcoidosis, even in the absence of pulmonary symptomatology. So those are just some of the wild thoughts I have. In terms of surgical treatment, I think a surgeon will definitely be involved. It would be nice for a surgeon to be involved here, because if that spleen is causing too much anemia, and there is a possibility, I don't know, maybe Paulus can tell us, but there could be a possibility of a splenectomy as well, with a histopathological assessment. Those are just my wild random thoughts. Thanks.
And Paul,
Thank you.
if you did the surgery, it would just be splenectomy. Would you give what vaccinations beforehand and how long beforehand?
Yeah, so that's a brilliant question. So right now there's a bit of thinking around because of course when you remove the spleen, your biggest worry would be for the encapsulated organisms. So definitely I would think around the meningococcal vaccine, the quadrivalent meningococcal vaccine, as well as the pneumococcal conjugate vaccine. If I'm not considering any immunosuppression as part of the surgical thinking, I'll probably do it either before or after, if there's no evidence around if I'm going to do immunosuppression post-surgery, then I'll definitely want to do a lot of the vaccinations beforehand. But if there'll be immunosuppression, if there'll be possibility for immunosuppressive therapy after surgery, then definitely I'll give most of my vaccines beforehand. But if there'll be no immunosuppression, I can give either before or after. It doesn't really it will not really alter as much. But maybe there are other thoughts around that. But personally, that's how I would approach it.
Interesting. Okay, well, thank you for commenting. Paulos, I guess there's another question here about the small bowel and if there could be a small tumor there. There's, I'd also mention that if there's amyloid in the gut, the mucosa may not obviously appear infiltrated. It's now or inflamed. It's not, doesn't look like a colitis, for instance, but the mucosa often is very friable. So you take a biopsy and it seems to bleed and bleed. It stops. But did you consider taking duodenal and colonic biopsies to look for something like amyloidosis? And was the mucosa friable or bleed easily? Paulos, are you there?
Hello, Prof.
Yeah.
Sorry, can you repeat the questions? I was
Oh, I
just having some
asked if you
interruption.
considered taking biopsies of the duodenal and colonic mucosa. If it's infiltrated by amyloid, it won't really appear as a colitis or duodenitis, but it tends to bleed more than normal after you take the biopsy. Tends to be friable.
Yeah. The problem was, Prof, as I already said, he was having a very low platelet, and initially we were not having the confidence to take some biopsies, but when we see the mass on the stomach and some infiltrative lesions, it's a kind of it's not infiltration, but it's a kind of erythematous in the lower pole. So I just dare and take some biopsies, and we just transfused the patient before procedure actually, but the platelet count doesn't go above 11,000. But we were hoping that, yeah, so that was the other things, but we can also consider re-scoping the patient for duodenoscopy and I mean for EGD, and we can do some duodenal biopsies if that can help.
And
The other question that we were having was a trial of steroid, because the hematologist was tending, I mean, she was thinking of Evans with, you know, a kind of hemolysis and low platelet count. So we were arguing on that point because we don't have any explanation for this. And I was asking if Evans can cause significant weight loss and kind of GI symptoms, and we try to look for on literature, but there is no significant association on Evans and significant weight loss or diarrhea.
What is Evans?
What do you consider? Pardon?
What is Evans?
Evans is it's a kind of hemolytic anemia, autoimmune hemolytic anemia with thrombocytopenia. So she finally considered that issue after consulting an ID. So the ID specialist also, you know, was considering non-infectious causes, and she want to try with because of the repeated, as I said, the patient was having repeated decline in the platelet count and the hemoglobin was also declined. Since he's been here, it was almost a month, and we transfused twice with platelet, and we also gave 4 unit of packed red blood cells. So we were desperate to consider surgical treatment or steroid trial with Evans and the likes. So what do
So we're coming close to the end of the hour. So I'll say the practical suggestions we've heard so far are to review the CT. Is the spleen really homogeneous, or is there a focal lesion to target? To consider cultures of something for TB, even if it's the stool, which I think is a reasonable suggestion. The patient has diarrhea, so culturing his stool for TB seems reasonable to me. Imaging the small bowel with enterography of some sort to look for a missed lesion there. I suggested duodenal and at least rectal mucosal biopsies and SPEP and urine immunoelectrophoresis, thinking about amyloidosis. There's a suggestion of further workup for a hemolytic disorder with Coombs test and maybe other testing for hemolysis. Those, I think, are the main suggestions. If there's others I've forgotten, missed, excuse me, somebody, you could put it in the chat.
Yeah, I think Dr. Helen is already in the group. If she want to say anything, she can because she was one of the hematologists working on that patient.
Oh, fantastic. Dr. Helen, do you want to unmute and comment about this case?
Thank you for joining, Dr. Helen. Yeah.
Thank you for inviting me for this presentation. This patient was a very challenging case for me. That's why I needed a multidisciplinary team to manage him. Initially, the patient came from Eritrea, and he was treated for megaloblastic anemia, considering he had pancytopenia. Initially, he had on and off form of jaundice. That's why I'm considering hemolysis, because he had some sort of treatment while he was in Eritrea. What treatment he got, the improvement, the progress, we actually don't know. And when he came, he had significant weight loss. He had abdominal discomfort. The main complaint when he came was significant abdominal discomfort, on and off diarrhea, and fatigue. No active bleeding from any sides. So when we evaluated with Dr. Paulos, what we found was the low hemoglobin and platelets. WBC was normal. I did bone marrow aspiration in biopsy, both of which showed unremarkable finding. Even the bone marrow was hypercellular, which is telling me that this hemoglobin and platelets are being distracted somewhere. So the bone marrow is compensating. It was hypercellular, normoblastic maturation, megakaryocytes were adequate, is 73 something. So I would have expected the bone marrow to be at least 30% cellular, but his was markedly elevated cellularity. That's with that of hepatosplenomegaly. That's why I considered Evans syndrome, where there could be autoimmune component where one or two of the cell lines could be affected. The other thing we considered was chronic lymphoproliferative disorder, like that of lymphomas. Low grade could give us such a picture, but we could not get a sample from anywhere where it would suggest in the line of lymphoma. He had no lymphadenopathy. The organomegaly, the hepatosplenomegaly was diffuse. There was no localized lesions from where we could take the sample so that we can send for immunoflow or any of those labs. So he was a very difficult case. So even considering a chronic lymphoproliferative disorder with marked organomegaly, causing sequestration with peripheral destruction is my consideration. So I was pushing in the line of the trial of steroids. So this was our challenge.
So thank you, Dr. Helen, for joining us and for commenting. You know, we're just about done with the hour. So Haile Mikhail, I'm thinking we should draw this discussion to a close. But Paulos, we're really, and Dr. Helen, we're really going to want follow-up about this case. If you do any more investigations, even in the next couple of weeks, you could give a couple of minute update next week when we meet in 2 weeks' time, or in 4 weeks' time. So I thank you both very much for really a fascinating case, and thank you everyone on the call for contributing to the thinking about it. Haile Mikhail, did you want to comment?
Yeah, thank you everyone for the call, and also Dr. Paul, I have invited him. He was busy, and thank you for joining us from the infectious disease, and Dr. Helen for the hematology. So it's good MDT team and all the participants. I think the two most important also recommendations from the group. There are a lot. Probably we can provide them the summary, but I think further evaluation of the small bowel with different approach, and any way to get sample from the splenic aspirate, or any other way, like by sort of transfusion and taking sample from the spleen, was the one recommended. Probably that is the only site probably you have to get tissue samples. Probably that's what we can say, and Dr. Paulos will update us further. And I think it's time, and thank you all for joining us today.
I'll mention that in 2 weeks, our speaker is Dr. Amindra Arora, who's a professor of gastroenterology at Mayo Clinic. And Amindra works in the esophagus clinic there, and he's going to talk to us about GERD, or esophageal reflux. And he's going to talk about things like what to do with a refractory GERD patient, when to consider surgery, and how to decide who should have surgery, what to do with patients with reflux symptoms that don't seem to actually be due to reflux. What should we do about all the recent concern about long-term PPI use? So he's going to discuss all these issues with us in 2 weeks' time. So we'd love to have you join, and we'd love it if you'd bring us your interesting cases, as Paulos did today. One of you in the chat has already mentioned a case. So I'll put my email in the chat. Please contact me, send me an email, and tell me about your case that you'd like to present. Because to continue as a clinic, we really need to have contributions from all of you. So,
yes, yeah.
Haile Mikhail, do you want to have the last word?
Yes, thanks so much, and see you in the coming 2 weeks. By the way, today has been our 3rd year. I just forget.
Nice.
So it had been 3 years, and it was really great moving together. So you'll have more years if you contribute more cases and if you actively participate.
All right. Thank you, everyone. We'll see you in 2 weeks.